Good morning, everyone. My paper is on knowledge, attitude, and practice pattern regarding compliance with spectacle use in children and in young adults. Uncorrected refractive error is the leading preventable cause of visual impairment worldwide. It affects learning, development, productivity mainly among school-age children and young adults. Prescribing spectacles alone is not enough. Consistent wear is essential. WHO emphasizes school screening, affordable correction, and behavioral change intervention as essential strategies. The objective of the study was to estimate knowledge, attitude, and practice pattern regarding compliance with spectacle use among children and in young adults. It was a hospital-based study conducted among 48 participants below 30 years attending a secondary care eye clinic. It consists of a well-structured questionnaire with 8 questions in each session, knowledge, attitude, and practice. A scoring of 3 to 1 were given according to the responses. Total score of 0 to 8 were classified as poor, 9 to 16 as average, and 70 to 24 as good. The data was later statistically analyzed. It was found that the mean age was 14 plus or minus 4. 52% were female, 60.4% were students. Out of 24 possible points, 20.7 was the knowledge score, 21.6 attitude score, practice score was 18.9. As you can see, while 89.6% of the participants demonstrated good knowledge and attitudes, only 58.3% showed good practice behaviors, revealing a significant gap between understanding and implementation. On comparing the spectacle use pattern, only 39.6% of the participants demonstrated regular spectacle use despite 89.6 having good knowledge and attitude. Moving on to the knowledge assessment, knowledge was strongest regarding spectacle customization and vision checkup. Knowledge gap were most evident in recognizing subtle vision problem symptoms. You can see only 52.1% correctly identify permanent vision loss as potential consequence of uncorrected refractive errors. 91.7% correctly identified the recommended time frame of 6 months to 1 year for vision rechecking. Moving on to the attitude assessment, maximum positive attitude was for the questions on importance of vision checkup, screen time effects, and wearing glasses. Attitude was lowest regarding the role of outdoor activities. The highlight points, as you can see here, is social comfort with spectacle wear showed room for improvement. Majority agreed that regular spectacle wear is important for eyesight maintenance. It was also seen that 29.2% participants were unsure or believed that spectacle would worsen eyesight. Moving on to the practice assessment, most of the participants obtained the glasses after cycloplegic refraction in the hospital. The lowest performance was infrequency of spectacle use. The primary reason for not using spectacle were cosmetic reasons and history of lost or broken glasses. Less than half of the participants had regular eye checkups. Almost half faced teasing for wearing glasses. On correlating the domains, knowledge and attitude were moderately correlated, whereas correlation with practice were weak and not significant. On comparing the knowledge level and spectacle use, it was seen that knowledge level alone does not predict compliance behavior, suggesting other factors beyond education are crucial for improving spectacle use adherence. On comparing attitude level, attitude may play an important role in compliance than knowledge, though the relationship is not definitely established in this sample. As you can see here, among regular users, 100% had good practice, whereas in irregular users, 31 had good practice. Practice behaviors are directly related to compliance patterns, hence validating the importance of addressing practical barriers to spectacle use. On looking onto the distribution of amblyopia cases, 39.6% of the participants were diagnosed with amblyopia. Their compliance rate were less than the non-amblyopic patients. Most of the barriers that were seen to spectacle compliance were social stigma, forgetfulness, durability issue, and also lack of follow-up services. Moving on to the discussion part. Despite good knowledge and positive attitude, regular spectacles use among children and young adults remain low, similar to a study conducted by LMIUA. Among those participants who reported not using spectacles, cosmetic concern and history of lost or broken glasses attributed to the non-compliance, whereas in a study conducted by Morjariopi, it was seen that teasing or bullying by peers were the primary reason. In our study, 12 of the 19 amblyopic patients were irregular users, and overall 37.9% of the students' population was amblyopic. A concerning finding given that amblyopia is preventable and treatable if addressed early, similar to study by Derar et al. The results show that only 39.6% of the participants demonstrated regular spectacle use. And also it was seen that 12.5% believed that leaving refractive errors uncorrected would result in nothing serious, indicating a significant knowledge gap that could lead to treatment non-compliance. These trends emphasize the need for targeted intervention, including education, early screening, timely treatment, and consistent reinforcement of spectacle use. Community-based vision screening programs and health educations are essential to reduce the burden of amblyopia-related visual disability. The study limitations here were because of the small size, it limits the generalizability. Because it was a cross-sectional design, it cannot establish causality. It was a self-reported data and a single-center study which may not represent diverse population. To conclude, the study shows a clear gap between knowledge and actual spectacle use among children and young adults, with irregular users, even in small populations, showing higher rates of amblyopia. This is important because inconsistent use can lead to permanent vision loss. Practical interventions like school screening, education, and addressing concern about cost and appearance can improve compliance. Ultimately, a regular spectacle use is essential to protect visual development and prevent avoidable impairment. These are my references. Thank you.
Realized it or not, this is called SBCC, Social and Behavioral Change Communication. You are trying to, as you nicely pointed out, knowledge is not a constraint. Everybody knows they have to wear glasses, but they are not wearing. That is the issue. So how to correct it? And you have come, your recommendation is again to spread more awareness, more knowledge. That is not needed. That will not have any value because the whole cohort which you have studied have enough knowledge that it should be worn. Probably saying that a broken glass makes them not wear glass, then the solution will be if I give two pair of glasses to every child from now on, will it increase their wear time? Will it avoid that handicap? All these becomes issues. All these becomes implications of your inferences. So in that way, we will have to check more. We will have to check more. We will have to try into this study. We'll have to add interventions like if the school teacher pointedly asks why you're not wearing a glass and makes the child wear a glass, will there be a change? So we'll have to go out of this knowledge increasing, awareness increasing agenda to other interventions so that they might increase the time. Cosmetic difficulty, cosmetic unappealing nature, making it a less want thing. Can we change it with making the frames more cosmetic? Can we make more designing into spectacle frames? Those are the issues. Okay. So those that way, I like you to continue this study. It's a very good study. It's a SPCC study, in fact, and this will be better if you add interventional protocols into that and try to see whether they have impact. Than to come and say that again will increase awareness. Awareness will not.
So I said it's reinforcement. However, we can, what types of, teachers, parents, siblings, all these people must be, the reinforcing sources for the child to wear the glasses. That's where I think we need to act.